started the timer and here is the question.
Okay. Okay.
Right. So if you have read and understood, kindly begin your examination.
Okay. So after entering the room, I will wash my hands and introduce myself and confirm the name and age of the patient. Then I'll take the permission from the patient to examine his knee and legs, which will include the looking, feeling, and moving the knee and legs. I'll request the patient to take off the gown and keep it on shorts only. I'll help them for that. Help him for that. I'll ask if he has any pain right now, need any painkiller, and can I examine? Then I'll ask the patient to stand, and I'll see if he's using any walking aid like crutches, cane, which is if it is present with the patient. Then I'll take a close look from front, side, and back of both the knees for any swelling, a scar, wasting, or deformity. And then I'll ask the patient to turn him around and then inspect the popliteal fossa also for any swelling. After that, I'll ask him to walk for a few steps towards away from where he's standing and turn around.
So patient refuses
and
to walk. What would
if
you
patient
do?
refuses to walk, I'll immediately apologize and I'll ask if he needs any analgesics immediately. And then I'll
And
take
if patient
permission
says,
from
no,
the.
it's all right, I don't need analgesics, but still I will not walk, what would you do? How would you convince the patient?
Okay, then I'll move on to the next examination. I'll inform the examiner
Yes,
that the
you'll
patient
apologize
has
and you'll
severe
accept.
pain.
Okay.
I'll apologize and also inform the examiner.
Yes.
Then I'll ask the patient to lie down on the bed. And
Yes.
Again, I'll say that I'm going to touch his knee and leg. And if I'll be very gentle, and if he feels any pain, he can stop me immediately.
Yes.
And first, I'll do all the tests bilaterally. I'll feel the temperature with the dorsum of my hand. And
from which side would you begin first?
I will start the temperature from the normal side.
Yes.
First,
left
and
knee. Yes.
First left knee. I'll do the from feet up to the knee. I'll do the temperature, and then we'll go to the affected side. After that, I'll do the bimanual palpation of bony prominences, scene of tibia tubercle,
Yes.
medial and lateral aspect of the inferior border of the patella, and then femoral condyles and tibial condyles, also the head of the fibula, and then lastly joint line on both lateral and medial side for any tenderness.
Yes.
After that, I'll palpate the patellar quadriceps tendon and also the collateral ligaments on both medial and lateral side.
You were trying
Then
to, yes, you were trying to do tenderness, or you were trying to palpate it, but patient felt pain.
For tenderness, yes.
Yes.
Yeah,
yes.
if patient feels pain, and then I'll again apologize, and then I'll go for next examination, and I'll again see the popliteal fossa if there is any collection or not, or any cyst. Then I'll feel the popliteal artery pulse by flexing the knee 15 to 30 degree and with the fingers keeping the thumb on anteriorly. After that, I'll do the patellar tap test, for which I'll empty the suprapatellar pouch with my left hand, sliding it downwards, and then with the right hand I'll press with fingertips press the patella and feel if there is any tap I can feel with the over the fingertips. If patellar tap is negative, then I'll perform the bulge test. If there is any small infusion, it can be detected. Then after that, I'll measure the quadriceps circumference which is about 10 centimeter above the patella, and compare on both sides if see if quadriceps is normal or any atrophy.
Good.
After that, I'll ask the patient to do the active flexion and extension by bending and extending the knee fully if possible on both sides. If there is a pain and patient refuses, then I'll move to another test. I'll try to do the passive movement with myself and feel the joint. But again, patient if has severe pain, he can refuse, and then I'll move to the next test. I'll try to do the anterior and posterior drawer test and posterior sag sign. First, I'll flex the patient's both knees to 90 degree and see if there is any posterior sag, which can give the false positive anterior drawer sign. After that, I'll sit over the patient's feet, partially pressing it with over sitting it, and then I'll try to push the proximal tibia anteriorly, first on the normal side and then on the affected side, and see if it moves anteriorly or not, and anterior drawer test is positive or not. Then I'll push it backwards posteriorly. If any significant movement, then the posterior drawer test will be positive. And after that, I'll do the Lachman test, for which I'll hold the proximal tibia with one hand and the distal thigh with the other hand, and try to move the tibia anteriorly against the thigh and see if it moves or not. After that, I'll do the varus and valgus stress test. Valgus stress test I'll do for medial collateral ligament. What I'll do that I'll do the medial and lateral collateral ligament.
Should you be doing valgus test if patient is in acute pain?
If patient does not allow, if he is in severe pain, I will not do this test.
Yes.
I'll move on. And also I will then go for McMurray's test. That also, if patient is painful knee, then I will not do that.
Case now?
Okay, finally I'll thank the patient and I'll help him to put on the gown, and I'll tell him that I'll discuss the case and inform him accordingly, and then I'll wash my hands. To complete my examination, I would like to do the examination of the hip and ankle also, and also neurovascular examination of both lower limb.
Good.
Okay, so today I've examined this 20-year-old gentleman footballer who presented with severe knee pain, and patient saw severe antalgic gait and he refused to move due to this pain. And then I did not notice any scar or swelling. There is some swelling of the right knee, but there is no deformity or muscle wasting. And I felt some effusion also. And on palpation, the temperature was a little raised compared to the opposite side. I felt the popliteal pulse bilateral equally, and quadriceps circumference were normal. I could not get the full range of motion on the affected side because of the pain. The patient was in severe pain. I also did not do the
differential diagnosis.
On the basis of this, my differential diagnosis is most probably the anterior cruciate ligament injury or collateral ligament injury or meniscal injury. I'll also consider all.
How do you plan to manage this patient?
First of all, I'll send the patient for X-ray knee joint, AP and lateral view. After that, I'll also advise the MRI of the knee joint. And according to the result, I'll manage the patient. I'll give the analgesics and then I'll SP the knee joint. And also I'll start with the RICE. First, I'll give the rest and also ice packing and little compression, and then elevation of the affected limb. And when the swelling subsides and inflammation subsides, then I'll ask for MRI result. If MRI result shows
what are you looking for in MRI? What do you expect?
Actually, as per the question, I think I'm looking for will be the anterior cruciate ligament rupture or injury or meniscal injury.
Yes. Okay. Do you think patient would be able to participate in the training?
After the surgery, has to wait for some time to get recover from the surgery, at least 6 to 9 months.
Yes.
Only after that he'll get he'll need a gradual training to get active preoperatively. Like
If
before.
your conservative management fails, what can you offer your patient?
I'll offer the patient the arthroscopic repair of the anterior cruciate ligament
Very
injury,
good.
or if there is meniscus tear, then meniscal repair or mastectomy.
Very good. Okay. Right. It was very good. It was very comprehensive, very detailed. You knew your topic, you knew what you were doing. Just at the end,
Okay,
when I asked you, just wasted half a second, when I asked you, how would you manage this patient? So what are the best ways of explaining it? If now we can discuss that you'll have complete history and then examination,
Yes,
this is examination. So then
yeah,
after taking
I-
complete
yes,
history,
yes.
then
I
you'll
forgot
advise, yes, those
Yes,
managements that you have said, and then you'll discuss it in MDT, your meetings, and then you'll decide if,
Yeah.
what management you are going to offer to the patient. Just 2-3 small things you can add.
Yeah, in 2 lines we should
Yes.
add that. Yes,
Yes,
I'll take the
And-
complete history and
first, yes. Because history is very important in these
Yes.
sort of injuries. Post-injury.
yes.
Right.
Yeah,
One more
you're
thing
right.
I want to appreciate, that if you go back and listen to your previous recordings and then listen to this one, there's a lot of improvement in the way how you present. It was more speedy.
Thank you, ma'am.
Yes. So that was an improvement.
Actually, I try to practice.
Very
I try to
good.
practice to myself at home.
Yes. And that I can tell. That one can
Try
tell.
to practice it 2-3 times.
Very good. Yes.
List.
And if you do it 30 times, then imagine where you'll go. Very good. Anyone else want to add anything? Okay, started the timer, and here is your question.
Okay.
Is this the DAMA station?
Yes,
Yeah, you have to call to.
you have to call the surgeon and you have to explain everything.
Oh, I prepared
Were
some
you
other
thinking-
station.
Which
this
one?
was the one you told me.
Yeah, there's some.
Confusion, huh?
Should I stop?
It was.
Right. So if you have read and understood, kindly begin your examination. Communication skills station.
Hello, good morning. I am Dr. Shweb. I am the Senior Health Officer here. I am working for my consultant, Mr. John. So can I please, am I speaking to Mr. John as I have to inform him regarding a patient? Hello, Mr. John?
Yes, continue. Dr. Suman.
Nice to meet you, sir. I would like to inform you regarding a patient who was admitted in our ward. She had undergone Mrs. Seema. She was 78-year-old and she had undergone mastectomy. Today is the second day, and she had undergone along with axillary clearance. Currently, she is presenting with some axillary swelling and shortness of breath. There is some wound drain which shows about 20 about some amount of blood collection, and she also is having a her daughter wants to take her home, which is away from this hospital, and I have tried to convince her, but I have.
Have you tried to talk to the patient alone, apart from her daughter?
Yes, I have tried to speak to the patient as well, sir, but she seems to have been influenced by her daughter. That's what I feel out of the deduce out of the conversation.
Did you make sure if the patient was sufficiently alert to make her own decision?
Yes, sir. She is sufficiently alert to make her own decisions and she's competent enough.
But according to you, she was bullied into making this decision by her daughter, right?
Yes, sir. That's absolutely right.
Yes. What do you think has happened to the patient?
Sir, I think that the blood collection. So there are two scenarios in this which we need to deal with. One is the collection in the drain because of a reactionary hemorrhage occurring because of her mastectomy. So there might be a bleeding vessel which has to be evacuated later. And the second problem which we need to address is the shortness of breath, as she also has chronic obstructive pulmonary disease with some amount of liver function, liver failure. Left heart failure. She might be having going in for pulmonary thromboembolism.
Okay. Can you, okay. So what are your plans of action? In
Sir,
the case of if there any complication takes place or occurs?
So just like I mentioned that there are two problems we need to address. So the hemorrhage she's had, I will blood come the hemorrhage there is a drop and try to do a cross match so that the blood is made available in emergency. And regarding her shortness of breath, I would like to see that her renal function tests are normal and then go ahead and proceed CT pulmonary angiogram to see if she has. At the same time, even like to order for a D-dimer test.
Okay. Why would you want to do D-dimer test?
Uh, as I'm suspecting pulmonary embolism, secondary deep vein thrombosis.
Yes. Okay. So have you explained
So
all the warning signs and their symptoms to the patient?
yes, subsequently do remind the patient and her daughter that since they are quite far away from the hospital and shortness of breath, her health is our priority. So hence we need to give most attention, and this might lead to death as well. So I have already explained all this, but they are insisting on going back home even after my advice.
Okay. Have you informed the GP of this patient?
No, sir. Subsequently, I will write a letter to my GP mentioning her clinical condition,
Yes.
the advice on circumstances on which she was discharged, and the full details regarding the surgery done and her current situation.
Has the patient still the drain?
Sorry, sir, I am unable
Drain.
to comprehend
Okay.
what you said.
Has the patient still the drains in place? Are the drains still in there?
Yes, sir. Drains. Yes, sir. The drains are still there.
Okay. How much is the collection? Have you
I'm not
noticed?
sure about it. I will check it and let you know again, sir.
Okay. Right. What are your other plans?
Subsequently, following this conversation, I would like to explain the patient and the daughter that they might have norms because they want to go against medical advice.
Yes.
And they have been fully informed regarding the consequences of this. And since they are staying away from home, I would also give a medical advice saying that in case she develops increase in pain, swelling, shortness of breath, which increases and causes distress, or there is increase in blood discharge, she has to immediately a nearest hospital, or she can come to us, and we will always to drive out our hand to her and for to help her out. I will also tell her that I will leave my number with the nurse from where she can pick up the number and
Hello.
Mr. John?
Yes, your voice disappeared. Okay, sorry. Can you please tell me, patient still has shortness of breath, and she is post-op day. What measures would you do to manage shortness of breath?
I would manage the patient on by by a care of critical surgical protocol by maintaining patent airway and check urine breathing and circulation.
Okay.
And I would like to maintain the airway for feel and see if there is any obstruction or any in the path of the airway. And then if required, do chin lift, jaw thrust, and more of endotracheal intake required, and start with high flow oxygen. Then proceed with breathing, wherein I will do a mini fast chest examination, look for accessory rest, the trachea centralization, then respiratory rate as well as SpO2 by pulse oximeter. Then I will check the inspection if for the chest wall and auscultate for the equal air entry. If there is any abnormality, will accordingly treat, like if there is a hemothorax or pneumothorax, insert a chest tube. Then I will proceed with circulation, wherein I will check for the vitals, urine output, capillary refill, CVS examination, and CPP. And
Since
I
patient is
insert
COPD
two
patient, do
cannulas.
you think patient might be having a COPD exacerbation post-op?
Yes, sir. I will definitely consider it as option as a differential.
Then Bell has gone because we wasted 1 or 2 seconds. So can you please summarize your case and then
Yes,
whatever
sir.
you have discussed with me? Yes, your plan.
Here is Mrs. Seema, who is 56-year-old. She has undergone mastectomy, and today is the second post-op day for. She had undergone surgery for her breast cancer, and she has presented to us with on the second day with drain collection with blood, and there is also shortness of breath. She has comorbidities such as chronic obstructive pulmonary disease. After me persuading her in the best interest of her health, the daughter wants to take the patient home, and I've explained this to them, and have also signed the legal forms for discharge against advice, and give him the red flag signs. If any issue develops after the discharge, she will report immediately to the nearest hospital or to us.
Very good. Thank you.
Nice speaking to you, sir. Thank you and have a nice day.
You too. So, yes. Right. Feedback.
Ma'am, my router has suddenly got
Disappeared. Yes,
so,
we were calling you. So we.
I had to really, I missed some of the points, but that Dr. Sweb, actually, if patient has shortness of breath or ma'am is asking, means that means patient has COPD and I see she is developing some DVT or pulmonary embolism.
He did explain DVT,
So we have to
yeah,
go on the.
because when patient is
When you asked
already
about
have
this,
COPD, then risk is that patient is already taking steroids. And now that I don't know if this surgery was an elective surgery or was done in emergency. So when patient is already taking steroids post-operatively, patient shows that withdrawal reaction as well because of steroid.
okay. I missed,
So I wanted him
think I
to
missed
talk,
that portion.
yeah, tell a little bit about
About
that.
asteroid. Okay.
Yes, steroids.
Okay.
Because
I thought DVT. Okay.
DVT, he told himself, because axillary swelling.
Okay.
and
I missed that, ma'am.
Yeah. So I wanted him to add this point as well, because this is also one differential he has to keep in his mind. And then mild LVF.
Okay.
So yeah, that could happen. Even he would rule out heart attack and MI and all that. So since it's a post-op patient, so yes, he told all these. Good, thank you. Yes, and here is your question. Right. So if you have read and understood, kindly begin your session. Yes, you'll enter, you'll greet.
Dr. Bilal.
Hi, my name is Dr. Bilal. I'm one of the surgical doctors in the ward. Can I've been told that you want to talk
Actually,
to me. Can I
doctor,
confirm?
I
How
think
can I
I'm
help
very
you?
fine. I have nothing. I'm okay. So I want to go home. I don't want to stay in the hospital.
Uh,
It is very disappointing and frustrating.
I'm really sorry to hear about it. Can you please tell me what happened? Why do you want to go home?
Because I think I'm feeling okay. Nothing happened to me, and I have this hospital is really frustrating.
I'm sorry to know that. Can I please confirm what do you know about your condition so far?
The doctor told me that I had some trauma on the left side here and had some problem in the spleen, but now I feel okay, and I think I can go back to my home and other work I have to do.
Yes, that is correct actually. Unfortunately, you have hurt yourself in the spleen, which is an organ on the left side of tummy, and there is a possible bleeding inside the capsule of that organ. Also, there is a drop in the hemoglobin, which is blood count from 12 to 10, which essentially suggests that there is a possible bleeding inside the tummy. Because of that situation, it is very important for us to keep you in the hospital for in case if anything goes wrong, we can manage it immediately. Is
But
that all right with you?
doctor, you know, my wife has cancer, and she has an appointment with her doctor, and I have to go with her. That's why also I cannot stay here. You know, I have to be with her.
I'm really sorry to hear about your wife's condition. This must be very difficult for you. I understand it's important for you to go back up. How we can help you with that? We can for your wife to go along and to get that appointment. Would that be fine with you?
I want to tell you that I also have a job interview, doctor. That job is very apt also.
All right. Yes, I understand that job interviews is really important for you. Is there any way we can arrange another date for your the condition you are having right now, unfortunately, is a life-threatening situation. If you continue it may risk your life. So I strongly recommend and suggest that you stay in hospital till we are sure that you are out of any risk.
But doctor, I think I am, and my job is very much important. If I'll not give this interview, I don't know whether I will get another job or not. So it is very important for me to go there. So I want to go, even if there is risk. I want to go, doctor.
All right. Okay. So just want to make sure that you understand the consequences of going. If there's any bleeding inside your tummy, it can be life-threatening to you. Also, I would strongly recommend that if you feel any pain in your tummy or if you feel nauseous or dizzy, please contact back to us immediately. Would that be okay with you?
Yes, doctor, I will do that. No problem.
All right. So I require you to sign a document, a legal document. We will mention that you understand the risks and benefits, and I have explained you that what are the possible outcomes if you go against the medical advice, and all the risks have been explained to you. Are you happy with that?
Yeah, doctor, no problem. I'll sign that. I'll sign it because I have to go.
All right. Unfortunately, I was unable to convince you. I will bring that document and get it signed by you.
Okay, doctor.
Okay, so just a quick sum up. we have discussed that you are having a condition which is bleeding inside the spleen capsule, which has resulted in drop of hemoglobin from 12 to 10. This suggests that there's a possibility of bleeding inside the tummy, and it can be lining as well. So if you feel any pain in your tummy or dizziness or shortness of breath, please call us immediately. Is that okay with you?
Yes, doctor.
All right, thank you so
I
much.
accept the yes, doctor.
Is there anything else you want me to explain to you?
No, doctor. I can understand.
Okay, thank you so much.
Okay.
You still have 2 minutes and 20 seconds left.
You can ask the patient if you have understood.
Yeah, can you please tell me what have you understood so far?
Doctor, I understood that I have some fracture here and got the trauma in the spleen, which may bleed and it may cause danger to my life also. And if I got any pain or any dizziness or anything, I'll contact the doctor immediately. And whatever happens to me, I'll only be responsible for that. And I will sign a document explaining all these things. So whatever will happen, I will be responsible and taking that risk.
Okay, thank you for your understanding. We are here to help you and support you. If there's anything else, please let us know. We will be more than happy to help you.
Yeah. Okay. You should also put the phone number if I want to contact.
Yeah, we will give you all the contact details to contact us best.
Okay.
Good. Still have 1 minute. Did you tell all the signs and symptoms which can get worse?
The pain inside abdomen, dizziness, nausea,
Yes.
Loss of consciousness.
And also to have someone to accompany him.
To accompany him, yeah. That I didn't mention. Yeah, sorry. Yeah.
Right, and then agree to let patient discharge, but with a memo to seek medical treatment as soon as he reaches back home. So,
yes.
And did you offer him to speak to his wife? But he declined.
No, I didn't offer him.
Yeah, and then employer for giving talk to them.
Actually, it's a job interview, ma'am.
Yeah, but then patient is on leave as well. Okay, alternatives of home leave. So, and then interview is in the next town. It's not in this place. So.
All right. Okay.
Yeah. Now bell went. Okay, good. Because both of you were so new, like you both knew the case, so you went so quickly. Otherwise, it's better to take full time, like complete your time.
Yeah, actually, I'm not aware of all the questions in the station. There are only few written in the Bazit note.
But
there
then
must
you
be
can
some.
read the other sing notes as well.
Okay, all right. Okay, yeah, sure.
Okay. Yeah, good. Started the timer and here is your question. Yes, please. Right. So if you have read and understood, kindly begin your examination.
Yes. I entered the room while washing my hands. Good morning, sir. Good morning, ma'am. Good morning, miss. My name is Dr. Shoaib. I'm the senior health here. May I please confirm your name and age?
after that? Because there'll be no patients in
After
exam.
that,
Yeah.
I will say that I'm sorry to hear that you've been having chest pain from the past 4 hours. Would you like to have an analgesic? And then I will say that today I'll be performing look, feel examination of your chest, which will involve look, feel, move, and some special tests. Does that sound all right with you? Do you need a chaperone? And then I will help her undress, and then I will ask, are you comfortable right now? And any point of examination, if you feel any pain, kindly let me know. I will immediately stop my examination.
Yes. What
So
would be the position of the patient during your examination?
during the examination, the position of the patient will be supine with 45 degrees
Yes,
elevated
in the couch. Okay, good.
on the couch. First, I would start by examining the face. I would look for any, I will ask the patient to lower the lid and check for any sinus pallor. Then I would like to check for any xanthelasma and cornea for any arcus senilis. Then ask the patient to open the mouth and check for any stomatitis or any pallor and central cyanosis. Then I will say that I will next move on to examination of the hand. I will check for any pallor and clubbing and peripheral cyanosis. Then I will check for xanthomas
What
and
would you find on the hand examination, which you expect to find there?
there might be signs of peripheral cyanosis and may or may not have clubbing.
Yes, and tar staining because patient is smoker
Yes.
since many years. Okay. Yes, please. Next.
Then next, I would proceed with, I will say that I will perform the examination of the chest, and then I will check for any scar marks, and then check for any dilated or engorged veins.
Yes.
Then I will inspect the chest, and then I will proceed with examination palpation. In palpation, I will examine for the JVP, and then I will check for the trachea centralization. I will proceed to then palpation of the pulse, check for the rate, rhythm, volume, and character. Then I will check for the apex beat. I will
Where would you find the apex beat?
first I will localize with my palm of the hand just below the nipple, and
Yes.
then I will count the ribs. That is from the second sternal angle downwards in the fifth intercostal space along the mid clavicular line will be the apex beat. I also accentuate by apex beat by asking the patient to lie down in the left lateral position. Then I will check for any palpable murmurs or thrills or heaves with the heel of my hand over the sternal, either side of the sternum. Then I will check for
Where
hepatojugular
would you find, yes, carotid thrill? That
carotid
position. Yes.
along the neck in the carotid arteries.
Yes, but how would you turn the face on the side and then how you look? Where exactly would you find it? Okay,
I'm
next.
not.
You'll tell me later. Okay, next, please.
Then I will check for hepatojugular reflex. I will tell the patient that you might have slight discomfort because I'll be applying pressure over the abdomen and checking over the neck for rise in the jugular venous pulsations. Then following that, I will proceed with auscultation. In auscultation, I will check for the heart sounds. The first will be checking for the aortic area, that is in the second right intercostal space, and check if there is any murmur, which might be aortic stenosis or regurgitation. And then I will
What are
check
the
for the
normal heart sounds that you expect to hear?
that is S1 and S2.
Yes, and then what would be the abnormal heart sounds that you might find?
If there is a ejection systolic murmur as seen in aortic stenosis, there
Yes.
would be a sound after S1 and before
Okay.
S2.
Yes.
And aortic murmurs are classically radiate to the neck, and
Yes.
we will help accentuate it by asking the patient to lean forward.
Yes. Okay. Next.
Then I will auscultate in the with the diaphragm of the stethoscope. I will auscultate in the mitral area and check for any murmurs. So the classical murmur for mitral stenosis will be mid-diastolic murmur, which accentuates in the right lateral position with breath held in inspiration. And these murmurs, especially the mitral regurgitation, mitral stenosis, radiates to the axilla. Then I will auscultate for the lung base for any
Yes.
crepitations by asking the patient to lean forward and check for the on posterior aspect auscultate with the stethoscope. Finally, I will conclude my examination by checking for sacral edema and pedal edema, and look in the legs for any scar marks for great saphenous vein grafts. And now I have completed my examination. I will help the patient to dress, and then I will.
Then you'll do the measurement of blood pressure as well, maybe.
Sorry, ma'am.
Blood pressure measurement.
Yes, I will check in the charts. If not mentioned, then I will do the measurement for the blood pressure.
Okay.
And then I will say that further steps will be taken, and you'll be informed subsequently. And have a nice day with a big smile. And while washing hands, I'll turn towards the examiner.
All right, good. Okay, can you please summarize your case? 1 second.
Today I have examined a lady with name Mrs. So-and-so with age. She is presented with chest pain, and have examined her cardiovascular system. On inspection, she is having the examination of the face. There is no abnormality. In the hand, there is cyanosis with clubbing as well as star staining in the hand, in the fingers. And the examination of the chest, there is with no visible pulsations. There is a visible apex beat, and on palpation there is palpable thrill heard in the thrill heard in the over the left aspect of the sternum. On auscultation, there is the two heart sounds were heard. There is no murmur, and
So
the
what are
lung
your
bases appear
differential
normal.
diagnosis for this patient?
I would like to give a differential diagnosis of myocardial infarction. I would also like to keep in mind other diagnoses such as left heart failure and infective endocarditis.
Okay. So how do you plan to manage this patient?
I manage this patient with, based on 4 main modalities: clinical, lab, imaging, modalities. Clinical, I would perform a full peripheral vascular examination along with peripheral vascular with respiratory system examination.
Yes. Can you help me to read this ECG, please? What are these red?
Yes, this is the ECG showing left venous hypertrophy, left heart strain pattern with positive deflection in lead 1 AVL and negative deflection lead 2 and AVF, probably suggestive of aortic stenosis.
Okay, so what sounds are audible in aortic stenosis on auscultation?
There is a split S2 sound and ejection systolic murmur, which radiates to the neck and accentuates on leading forward.
Yes. Yes.
The other clinical finding is there might be water hammer pulse.
Good. What precautions would you advise this patient? Bell is gone, but we got late. So please, what precautions would you take, or would you advise this patient?
I would ask the patient to avoid strenuous activity, as aortic stenosis is a triad of chest pain, dyspnea, and syncope. So avoid strenuous activity.
Yes.
And to lifestyle modifications such as avoid control of diabetes, hypertension, and avoid smoking.
Yes, very good. Very
also
important.
refer this. Yes, ma'am. And also refer this patient and advise them to see a cardiologist for further investigations such as 2D echo and transesophageal echogram.
Okay, good. All right, now very good. Okay, you knew okay, it's no hard and fast rule with what differential diagnosis you give to the examiner, but whatever differential diagnosis you'll give, you should be able to justify them. So the first one was MI, and the second one you told, what was the second you told me? So MI,
left ventricular failure.
That's the second, and third was endocarditis. Okay, I don't know how you got that. Okay, because there is no history of fever. So and then most importantly, elderly is written. When there is elderly, then aortic stenosis is most like it can happen, and then MI is also most possible because it's only the history of 4 hours. But then MI and 4 hours history becomes little too long, don't you think so? because MI within 30, okay, pain becomes really sharp, and whatever people do, they do it immediately. So even then, MI is little vague kind of.
It will be anginal pain, actually.
Anginal, yeah,
Yes.
angina can be,
Yeah.
yes, but not
Diagnosis
angina.
will be aortic stenosis. And
But
causing
first
angina.
differential MI is little loose game, you know. I don't know, but can be.
Yeah, but actually, ma'am, in examination, only 5 scenario comes. No other.
Yes.
Till
5
now,
scenario
there is
comes.
no MI or anything else. Only
No.
5.
And then you have
That is
to come out of those 5 scenarios. Yes, please.
Yes. That is aortic stenosis, mitral regurgitation, and a pacemaker, and
Yes.
valve replacement.
Valve replacement. Then you would have to look for the scars.
Valve replacement with mitral
With mitral
regurgitation.
Sorry,
regurgitation. Yes.
I couldn't hear the last minute conversation. What is the most common scenario in exam? You were saying something, Dr. Suman?
It is the first scenario, aortic stenosis, like this, where there will be some chest pain. Okay. And second is mitral regurgitation. Third is
Mitral
pacemaker.
regurgitation. And what was the first one?
Aortic stenosis.
Okay.
Aortic stenosis.
Sorry, my
And-
voice is something wrong with my connection. Sorry. Thank you.
That's
fourth,
okay, no problem.
Fourth is valve replacement.
Yes.
Okay.
And
fifth
in
is
that
valve
one,
replacement
there'll be
plus
midline.
MR.
Yeah, 5th one is that. And there'll be midline
Yeah.
stenotomy scar, and there'll be audible metallic click of prosthetic valve. So you would be able to hear that.
Yeah.
So these are the most common ones. MI you can have as a third or third option, of course, because that comes in DDT, differential diagnosis, but not as first.
Okay, ma'am.
Maybe MI started with angina, but later on went to MI. That can happen.
Yeah, angina, then unstable angina, and then okay, you can say unstable angina, and yeah.
Then later on MI.
Dr. Samir, but the scenario says that the pain, chest pain is sudden and it moves to left shoulder. Then why we not call it MI as a first DD?
This is the history given by patient, right? Patient is feeling that pain is radiating there. But what examination you are doing, you have to conclude on your own. You can't just go everything with what patient says.
Okay, all right, thank you.
Actually, in such cases, the examiner will give you the finding.
Yeah.
What you find, what you did not find. Like on inspection, he'll tell you that there is midline scar, or there is nothing, or there is left infraclavicular
or
scar,
deviated
like that.
Apex feet, so you'll know.
Or deviated apex feet, like that.
Yes.
Yeah.
On examination, they'll tell you findings.
Which type of murmur.
Actually,
Because,
you didn't notice when Dr. Schwab was presenting, I asked him for carotid thrill because I wanted him to think on those lines. So yeah, they can tell you. It depends on their what findings they want you to know or to find.
Yeah.
Yeah.